My name's Kristin Kenrick. I have a particular interest in celiac disease, driven by a personal interest in celiac disease, having been diagnosed with celiac disease myself about 12 or 13 years ago. And at the time that I was diagnosed, it did not occur to me that this might be a possible explanation for the many years of episodic iron tablets that I had taken. I think the first lot of iron tablets I took was when I was 15, and I had been diagnosed with irritable bowel syndrome at probably around about the same age, 15, 16, something like that. And off and on over the years, that had caused me some symptoms, and I just took iron tablets. I got tired, I went to the doctor, I had my iron levels checked. Yes, my ferritin was 5, so I'd take some more iron tablets. And it never occurred to me that there might be anything else that might account for these things. And until one day, one of my children, my daughter was I think 2 or 3 at the time, and for some reason had a blood test that showed that she was iron deficient, and not very, but iron deficient. I thought, oh, maybe she's got malabsorption, maybe she's got celiac disease. And so I talked to our GP and I said, can we test her? And we both sort of at the same time, so I thought, perhaps we should test you for celiac disease as well. So it turned out I had celiac disease and neither of my children have celiac disease, which is good for them. But it caused me to stop and think, that, and it wasn't until I'd been on a gluten-free diet for probably only 6 to 8 weeks once I'd had the diagnosis confirmed and I went on the gluten-free diet, I actually felt much better in myself. I felt much better than I'd ever felt before. And I suddenly thought, so I actually haven't been feeling well. I thought that this was normal, that everybody was kind of aware of their sort of tummy kind of gurgling and making funny noises and being uncomfortable after they eat. I thought everybody was tired, especially with youngish children and stuff. And it wasn't until after I'd been on the diet for a while I thought, I actually feel really good. I feel like alert and interested in things. And I thought, if I couldn't recognise this in myself, how many of my patients have I not recognised this in? And I started to talk to some of my colleagues about celiac disease, and it was kind of not on our radar very often. And so that's what got me interested in it. Then I got involved with Coeliac New Zealand, and I have had quite a bit to do with Coeliac New Zealand over the last several years. And I kept hearing similar kinds of stories. That it took a long time to be diagnosed, and the blanket statement tended to be, GPs just don't know anything about celiac disease. I thought, well, that's not fair, but I want to find out what the actual, what the state of play is with things, and so, and what can I do to help with that? And so over that time, I have done quite a lot of work around celiac disease, and somewhat having a rush of blood to the head. Some years ago now, I enrolled on a PhD to also do some more formal research into celiac disease. And so some of what I'll talk about today is derived from my research, but most of it is just stuff that I've learned about celiac disease that I think is useful to pass on. So I think that this is important because that we all know about celiac disease because it's the most common hereditary autoimmune condition. The prevalence is at least 1%, and it's probably increasing. There seems to be evidence emerging that it is increasing in a number of populations, and it's still substantially underdiagnosed. And there's debates about how underdiagnosed it is. I actually think that in New Zealand we're probably not doing too badly in terms of actually picking up our patients with celiac disease, but worldwide it's posited that perhaps as many as 80% of people with celiac disease still don't know that they have it. And this was a study that was done in 2012 with nearly 1,000 New Zealand celiac patients, and the figure that is kind of alarming is this one here. So the average duration of symptoms between when a person first presented to their doctor with symptoms that could be explained by celiac disease and when the diagnosis was finally made was 11 years. And that was kind of consistent with my experience. Actually, was longer. And that's just because it just doesn't appear on the radar. You can't, well, it wasn't back then. You can't diagnose something if you haven't thought about it as a possibility, and so what I'm trying to do is get people thinking about celiac disease as a possibility more frequently. So 35% of the sample were diagnosed with anemia of unknown cause. I teach medical students. One of the things that I do is I teach 4th and 5th year medical students in Dunedin, and one of the things that we do talk to them about is if you've got a patient who you find that they are anemic, you need to go and find out why that person is anemic. Celiac disease can sometimes be an explanation for that. It's not the only explanation, obviously, but it is something to go looking for. The other thing is that 49% of the sample sought information about celiac disease from their GP or their GP practice. A lot of them weren't that impressed with the information that they'd been given, partly because there were lots of gaps in the knowledge of the people who were giving them the information. Probably the best source of information that most people find is actually from Coeliac New Zealand. But it's useful for us, I think, as GPs to kind of upskill ourselves, or at least be able to have access to the resources that we can put, and the same goes for many other conditions obviously as well, is to be able to put patients in touch with the resources that will be helpful for them. Okay, so for today there are two things that I would like to achieve, or or be outcomes for the day. One is that you'll think about the patients in your practice, that actually you haven't thought about celiac disease up until now, but actually possibly celiac disease could be an explanation for their symptoms or their presentation. So that's one. And the other is that you think about the celiac patients that you do have, and whether there are other things that you could be doing for managing them, apart from saying you're on a gluten-free diet, good luck with that. Now I know that's not how we behave towards our patients, but there has been a sort of a presumption in the past that the management of celiac disease solely revolves around the gluten-free diet, and that's up to the patients to be able to, patients themselves to be able to manage that. And there are some things, so later on today I will talk about some other things additional to the gluten-free diet that we should be thinking about for our patients with celiac disease. So as we work our way through the course of the day. So I'm talking now for the next bit, and then Sarah's going to talk about diet later on this morning. Then John's going to talk in the afternoon about IBD, and he's also going to pop in when I'm talking about the diagnosis of celiac disease to make sure I'm telling you the right stuff. And then at the end, I will finish this afternoon and we'll talk a bit more about sort of management of celiac disease beyond the gluten-free diet. Now, please feel free to ask me lots of questions. Just stick your hand in the air and ask questions if I'm rushing over stuff, if I'm skipping stuff out that you want to know about. Please feel free to jump in. I've got a few things along the way where I will be getting you guys to make some suggestions and talk about things amongst yourselves, but at other times, yeah, please feel free to interrupt me. So just by way of, I suppose, disclosures as well, so the PhD I've been doing, I have had funding from Coeliac New Zealand for that, and also from the University of Otago. The PhD has involved a survey of gastroenterologists, a survey of GPs, and an audit of about 10 years of laboratory data from Southern Community Laboratories, who are our main provider of laboratory services in Otago and Southland and in some other regions as well. I have to say, it has been a long and winding road doing a PhD, but I'm just about to submit, which is very exciting. So some of what I talk about today is sort of I've pulled from some of that research, and I'm happy to answer questions about other aspects of that as we go along. Okay, so what is celiac disease? I think we probably all pretty much know this now. It has certainly had a lot more attention in the last few years, but it is the most common of the autoimmune conditions. So people with celiac disease react to gluten. Gluten is the main storage protein in wheat, barley and rye. Technically, it's the proteins in wheat, but the proteins in barley and rye are so closely related to wheat that they're all sort of lumped under the umbrella title of gluten. So oats, the pendulum has swung sort of backwards and forwards about whether we should include oats as a grain that triggers celiac disease. the thinking now is that for a very small proportion of people with celiac disease, probably no more than 5% of people with celiac disease will also be sensitive to the protein in oats, but the protein is different enough in its makeup from the protein that's wheat and barley and rye that most people will be okay. The problem though with oats is that most oats that you can just buy at the supermarket, your Haraway's rolled oats and all the rest of it, are contaminated with wheat. And so a lot of people, so you can now get gluten-free oats, and what that means is oats that have been prepared separately from those other grains, and it may even include, and that contamination can happen anywhere along the process. It can be if they're harvested in the same, grown and harvested in the same or adjacent paddocks, if they're milled in similar in facilities in common, if they're packaged, all of those things. But you can now get gluten-free oats, and the majority of people with celiac disease will be okay with gluten-free oats. That's the current thinking on it. Coeliac New Zealand continues to err on the side of caution along with Coeliac Australia, and does not recommend that people with celiac disease include oats in their gluten-free diet. But elsewhere in the world, where if you can be guaranteed that it's gluten-free oats, then it's safe to do that. I suppose the advantage of oats is that oats themselves nutritionally have some advantages to be able to include them in the diet, and so there is definitely room to talk to patients about individual patients about the possibility of including oats for them. Gluten-free oats are expensive as well, so that's the other thing just to bear in mind, and they're not the ones that are going to be on special at the supermarket. So it's a systemic condition. Is the other thing to remember. We still regard it primarily as gastrointestinal because the gut is the primary organ that is affected by celiac disease, but it is actually a systemic disease, and numbers of the symptoms that people can present with are actually not to do with the gut. So that's the other thing to bear in mind. We can pick it up by doing the right blood tests. We should be confirming the diagnosis by getting our patients to have duodenal biopsy, and I'll come on to that in more detail later on in the discussion. And as I alluded to before, the primary treatment is removing gluten from the diet, but there are some other things that we should be doing with our patients with celiac disease to support them with living with celiac disease beyond just having them on a gluten-free diet. It is unique amongst the autoimmune conditions in that if you take gluten out of the diet, people do get better. So while you don't cure it, you have got the possibility of curing the majority of their symptoms as long as they maintain that gluten-free diet. And there are some other treatments that are being investigated and things which, if we get time at the end of the day, we'll just talk about those very briefly. So the current working sort of classifications of celiac disease that are featuring mostly in the research now are what's called the Oslo classifications for celiac disease. I have to say I'd love to be a gastroenterologist because they get to, they've got the Rome criteria for irritable bowel, there's the Oslo criteria for celiac disease, and there's some other some other international place as well where they go off and have their conference and to come up with these criteria. I'd quite like to go to Oslo. So classical celiac disease, that's the one that I was taught about at medical school. It was the little child or very young child, you introduce wheat into their diet and they start failing to thrive. So they're malabsorption, malnutrition, lots of diarrhoea, really unwell. So that's regarded as classical celiac disease. It is not the most common presentation of celiac disease in this day and age. Patients will have positive antibodies and they will have villus atrophy on their biopsy. Non-classical celiac disease is where as it says there, where the extraintestinal symptoms predominate. Now you can argue a little bit about where they say in the definition about there are no overt symptoms of malabsorption. So there's a bit of sort of arguing about where does the person who's got the person like me who's got irritable bowel syndrome and iron deficiency, where do they sit in this? Because you could argue that being iron deficient is a symptom or a sign of malabsorption. But generally we would regard someone who presented as I did as having non-classical celiac disease. This is the celiac disease that is most common. And we've talked about, previous definitions have talked about typical celiac disease and atypical celiac disease, and they used to regard this as atypical, but kind of wasn't making sense anymore to call it atypical when most people were actually presenting with that. Get the right button. So there's also subclinical celiac disease. So these are people who don't have any signs or symptoms, and they're usually the ones who are picked up by screening at-risk individuals, and so that might be first-degree relatives of people with celiac disease, or there are various other risk situations we'll talk about. Often these people, if you quiz them once you've diagnosed it and they are happy to accept treatment and go on the gluten-free diet, they actually will say, actually maybe I did have symptoms and I just didn't recognise that I had symptoms, because of its sort of chronicity, and a lot of people sort of, this is just normal for me. And that actually is the case for some children as well. Children who are being diagnosed sort of 7, 8, 9 kind of ages often haven't kind of realised that the way that they feel isn't actually the best that they could feel. And then there's this condition called potential celiac disease, where and these people can be picked up in different ways. So they've got positive antibodies, but they have normal histology when you do the biopsy. And there is a bit of debate about what to do with these people with potential celiac disease. Do they go on a gluten-free diet or do they not? And it would seem that is now starting to sort of fall into, there are sort of two groupings. If your patient is symptomatic, but got a normal biopsy, so they had elevated antibodies, normal biopsy, and they have symptoms, then probably it's worth trying them on a gluten-free diet, and it's probably appropriate for them to go onto a gluten-free diet and be managed as if they had more sort of say subclinical celiac disease perhaps. If they've got no symptoms, if they were picked up entirely on a screening thing with their positive antibodies and they've got no symptoms at all, then there is evidence to suggest that you don't need to put them on a gluten-free diet, and there's been some longitudinal studies that have been done now overseas where they've followed some of these people for 9 or 10 years, redoing their antibodies and redoing their biopsies, and they continue to have normal histology on biopsy. So there's something happening in there that we don't quite understand. And so these are probably some of the trickiest ones who've got positive antibodies, but the normal histology. Yep.
They can't get funding for gluten-free food then?
No. That's right. Yeah. So that's, So some people with, so have any of you had patients in this situation who've had positive antibodies but a normal biopsy? What's happened with those patients?
They've got wildly worse, had more positive antibodies in the second biopsy that was positive.
Yeah.
So they thought that they probably had skip lesions of...
Yes. So there's a couple of things in there. One of the reasons that you could wind up with potential celiac disease is you could have positive antibodies that are actually false positive antibodies. Autoimmunity can cause your tissue transglutaminase antibodies to go up, even if it's not celiac disease. So that's one possibility. And there are a couple of other things that can give you false positive antibodies, but that would be the most common. The other is that the biopsy only sampled bits of the bowel where it was normal, and certainly the bowel changes that go with celiac disease are patchy. So it is possible that you could luck out, as it were, and just sample from the bits of bowel that there is no evidence of celiac disease there. And the gastroenterology societies and that have tightened up quite a lot on the recommendations that they make about how many biopsy samples should be taken and where they should be taken from to try and get around that. And then there are some people who are truly, they were definitely positive antibodies, and they were definitely a negative biopsy, and they're the ones that are sitting there and we're not quite sure what's going to happen with them. And some of them will do what your patient did, will go on to develop more overt celiac disease, and some of them will just grumble on or not grumble at all. They'll just sit there with the positive antibodies and not go on to develop celiac disease. The other issue to think about is when they had their biopsy, were they consuming enough gluten in their diet when they had the biopsy for it actually to be a positive biopsy? And that, I think, is one of the issues that that we need to think about when there are delays between when people get their have their positive biopsy and get positive blood tests and get to have their biopsy. For some people, that is quite a long delay, and that varies up and down the country in terms of services that you have access to, particularly in the public sector. And so people need to be consuming gluten to have a biopsy. So all of those things will play into this. And there should be some discussion with the patient around what are their preferences. A knee-jerk reaction that the person should go on a gluten-free diet is not necessarily going to be the right response for that particular patient. And having a policy of watchful waiting, reviewing, is the other way forward for this. So there are risks. So one of the groups that they talk about screening for celiac disease in is kids with type 1 diabetes, because there's an increased association between type 1 diabetes and celiac disease. And I know that some of the paediatricians in my region will annually check celiac antibodies on their type 1 diabetics. Now that actually probably is a bit over the top. They probably don't need to be checking them every year if they don't have any symptoms that would be sort of suggesting that celiac disease has developed. The guidelines from the one of the paediatric gastroenterology societies now is that you test at diagnosis of type 1 diabetes and then have a low threshold for retesting if new symptoms emerge or if there are difficulties managing their diabetes, or but there isn't a time limit, a time range that they can say do it every 2 years, do it every 5 years. And the same would go for your adult patients who've got their positive antibodies, normal biopsy. When do I retest them? Well, yeah, it's the how long is a piece of string. Yep.
What about testing children of people with celiac? Because they've got a higher risk.
Yes. Yeah. So we'll come on to that actually, but yes, we should be testing first degree relatives of people with celiac disease. Yeah. Yeah.
Sorry. What about the adult patient with kind of what you think are IBS symptoms? Can you say to them your celiac test was negative last year, you don't have celiac disease that end, or you should be still retesting rather than just kind of pursuing that this is IBS and getting on with that management?
So there is one other option that can sometimes be useful in that situation, and that is the gene test, and I'll come on to that in a little while, is when is the appropriate time to use the gene test for testing for celiac disease. That can sometimes be an appropriate time to do it, and so we'll, yeah.
The black or white kind of test rather than the celiac disease. The celiac.
It's black or white if it's negative. Which is which we'll talk about. So a negative gene test can be really helpful in making those decisions about whether to screen or not to screen. Subsequently, a positive test is not going to help you very much. Yeah. Someone else?
I was just going to say, when you say, I always tell patients they've got to eat gluten before they have a biopsy, how much of what you tell them? Because a lot of people say, oh no, I'm not going to do that.
Yes.
And then you think, well, there's no point doing it.
Yeah. So I'll actually get onto that. We'll talk about the gluten. We'll talk. No, that's fine. No, we'll talk about the gluten challenge as sort of as we work through, because that information has changed actually as to how much gluten is a gluten challenge. Yeah. Okay. So when to look for celiac disease, which we've kind of been moving into anyway. So who gets celiac disease? So at least 1% of the genetically susceptible populations that consume gluten. Genetic susceptibility is conferred by this HLA DQ2 or DQ8. That's the test. That's the gene test the gene that we look for, or marker that we look for. Affects people of all ages from a wide range of ethnic groups, and this is another thing that we need to keep in mind. And it is, it's still significantly underdiagnosed. Now, what I don't talk about on this slide is age and gender. So how many of you have got patients with celiac disease under your care? Pretty much, quite a lot of you. How many of you have got men with celiac disease under your care? Much fewer, yeah. So it is an autoimmune condition, and autoimmune conditions tend to affect women more than they affect men. So it is thought that probably women do have celiac disease more than men do. However, in several of the population studies that have been done that are just the random prevalent studies in population where they pick up 1,000 people, like the one they did in Christchurch many years ago, they just check 1,000 people, test them for antibodies, then biopsy those with positive antibodies. The distribution between men and women is roughly equivalent. So, don't know on that one, but definitely the fact that men are less likely to present to the doctor for testing will be playing a role in this, but it seems probable or plausible that more women have celiac disease. Part of the study that I've just done has been looking at laboratory data from from Southern Community Labs, and so over the 10 years that I was looking at their lab data, there was something like 50,000 celiac tests processed. I can tell you that's a big spreadsheet to look at. The proportions of men and women being tested was around about 2 to 1 women to men, so roughly. So there are way more women being tested. But when I looked at the proportion of positive tests amongst men and amongst women, the proportions were around about the same. So I had kind of been expecting that if men were only presenting late, or if men were more like, if it was partly that men and women do have celiac disease at the same rates, but men just don't get to the doctor or whatever, I was kind of expecting that the proportion of positive blood tests amongst men might be higher, but it wasn't. So yeah, I'm still... Children, I think it's more even actually, but I can't actually, I haven't got that number in my head, but yeah, but certainly amongst adults, way more common in women than men. So the other thing I was going to ask, in terms of ages, how many people have got adults with celiac disease in their practice? Sarah, you don't count because you've got, they come to you specially. How many, so adults?
Yeah.
What about children? Yeah, so it's even, what age are the children roughly that you're looking after with celiac disease?
School age. Yeah.
School age?
9 and 12.
Yep.
School age.
Yeah, and the adults, what ages are the adults when they're being diagnosed roughly? 30s, yeah. So back in the day when celiac disease was the sort of the classical celiac disease, it was young children who were the biggest proportion of patients with celiac disease. These days, kids who are being diagnosed with celiac disease, their mean age is around about 8 years old. Obviously, there'll be some who are younger than that, and the people who present with really classical celiac disease with the malabsorption, they tend to be the younger kids, and it's probably because they're homozygous rather than heterozygous, so they've got a bigger dose. But the mean age for children presenting and being diagnosed with celiac disease is around about age 8, and the median age for adults is around about 40. So it's 30s through to 40s. In the data that I looked at, I think the oldest person who was being diagnosed for the first time with celiac disease was 85. So that's the other group, and there's been a bit of research being done recently about looking for celiac disease in the older population. So it's not something that we should forget. I used to think, and certainly the research used to sort of point towards, if you're going to get celiac disease, you'll have it by the time you are 12 or something. So if you could test people up to that age, and if they didn't have celiac disease at that age, then they were never going to get it. And the adults who were being diagnosed with celiac disease were likely to be people who'd had it for years and years and years and just never been diagnosed. That is not the case. So people can newly develop celiac disease as adults and at any age as adults. And it's part of the great autoimmune mystery as to what are the triggers that are causing that. But we know you have to have the right genes. We know that you have to be eating gluten, but we don't know what else it is that's triggering that. And it's the same with the other autoimmune things. There's lots of theories. I'm sure you've got your own theories and you've heard lots of theories about this, but you can newly develop celiac disease as an older adult as well. So this is a slightly ghastly table to look at, but this is taken from a paper that was published in 2015 where they looked at the prevalence studies and some incidence studies across a wide range of countries. And so all of these countries here have prevalences above, as it says there, 0.7%. So, and these are ordered. So Burkina Faso has 0 celiac disease. They did a prevalence study amongst the population there, and nobody had celiac disease at all. And that's partly because the genetic, they don't have a very small proportion of the population has the right HLA marker, and it's also because they don't have wheat in their diet at all. The highest group was a group of refugees in Algeria, or within Algeria, and they had a prevalence just on blood testing of 5%. And they're thinking, so it wasn't biopsy proven, but they were reasonably confident in they did sort of double antibody testing. And they've got a high incidence of the genetic marker, they've got a high incidence of consanguinity, however you say that word, and they have a high wheat load in their diet. So they go from 0 to, that's the highest there. So New Zealand is quite up there. So I've ranked them like this. So the New Zealand figures come from a study that was done in Christchurch in 1990, and there were 1,000 people that they just randomly selected from the electoral roll, did the blood tests on, did the biopsies on, and they came up with a prevalence amongst that population of 1.1%. Of, at the time, only one of those people knew that they had celiac disease. And it's still one of the best prevalence studies that are around, actually. There are some methodological issues with some of these studies around what they counted as being positive, but this is the best that we have. So, a little quiz. Where would you put Japan? On the left side? Yep. What about northern China? Where would you put northern China?
Middle.
Middle? High? Low? So northern China is over here, and about 1% amongst the Han population in northern China. And this is a cause of concern for the people who are into sort of global population and health, because this is a huge number of people and their diet is becoming increasingly westernised. So wheat is becoming more and more of a feature in the diet, particularly in the northern parts of China. And so there are people predicting that there will be a real upswing in the number of people with sort of overt celiac disease. So northern China is on this side of the chart. What about Pacific Islanders? Sort of, I know that they're not all lumped together, but sort of where would you expect sort of some of our Pacific Island neighbours to sit on this chart? As far as we know, they're actually probably on this side here, the low side. There does seem to be, there's not many studies of HLA markers and things that have been done, so there certainly hasn't been a prevalence study done amongst any of the Pacific Islands, but there have been 1 or 2 studies looking at HLA markers or as a side thing from other studies, and most of the Pacific Islands have low levels of the HLA DQ2 or DQ8. But we need to remember this, so India, northern India in particular, so southern India are over here, that's why sort of some countries appear in both columns, but northern India is quite high, and one of the sort of researchers from India sort of said that the problem with celiac disease in India is that it gets lost in the sea of malnutrition that they have, but it's something we need to think about. Iran and Iraq as well. Our refugee populations, I think the reason I'm sort of raising this is because Syria is another one that would appear on this list. So countries on the Middle East, northern parts of Africa and around the Mediterranean all sort of sit at this end. Some of them will be in this middle thing, but some of them are at the high end. We need to be thinking about that in our patients from these other countries in terms of should we be testing them for celiac disease, and you know, particularly our former refugee patients. Because we could well be missing some stuff in there. So Germany, I was fascinated to see that Germany was over on this end, and they've done a couple of studies, and for whatever reason, Germany does seem to be, the incidence seems to be much lower. And it's hard to know why that is, because they do have reasonable amounts of the HLA markers, and they do have reasonable kind of wheat bread consumption. We had a German exchange student staying with us recently, and she seemed to eat quite a lot of bread, actually. And my daughter went to Germany, and she said, I had a lot of bread, Mum. So I don't think the diet totally explains it there. The other place that was really interesting was this place, the Russian Coeliac, which is right next door to an area of Finland, and they did a comparative study of the populations between Finland and this Russian Coeliac. And either side of the border, there were big differences. So Russian Coeliac was about 0.3%, and Finland was up well over 1%. Same diets roughly, same genetic kind of things. And so this is an example of where they think the only difference, clear difference between those two populations was socioeconomic status. So the Russian Coeliac is very poor and deprived, and the area of Finland that they were studying was not. And so that sort of brings in the whole hygiene hypothesis aspect to the development of celiac disease. Okay, so we need to broaden our picture a bit more in terms of symptoms that should kind of make us think about celiac disease. So this is, so obviously GI symptoms are the most prevalent that we think about, but there are some skin things like mouth ulcers. There's a bit of debate in the literature about infertility and miscarriage and the impact that celiac disease, undiagnosed celiac disease, has on that for women, but it's definitely something that should be thought about in a woman or a couple who have otherwise unexplained infertility, is whether or not actually celiac disease should be something to think about. Peripheral neuropathies is the other thing. You can get neurological presentations of it sort of as the only symptom that people are presenting with their celiac disease. So it's a much broader kind of picture. Do people know what dermatitis herpetiformis is? You saw it last week. Tell us about it, Caroline.
It was a really unpleasant looking blistery rash that looked almost like a herpetic rash, but it was bilateral, and it was in a young woman with type 1 diabetes and celiac disease.
Yeah. And where was it?
Tops of her thighs, around her hips and bottom.
Yeah. So it tends to be extensor surfaces, or so backs of elbows is the other place that you can look for it. But sacrum, buttocks, and maybe up around as you're talking about. So it's an intensely itchy, blistering kind of rash, and people who have and it's confirmed on biopsy. So how was this patient confirmed? Did she have a biopsy? You've got it because you've got all those other things. Yeah. So if you have someone who's presenting, this is just a side thing while it occurs to me. If you have someone presenting with a really itchy skin rash that's blistering and it's on those surfaces, like particularly elbows and sacral area is the other common area, and I think the back of the neck they can sometimes get it. If you want to biopsy for dermatitis herpetiformis, the biopsy actually needs to be from adjacent to a lesion. So you don't actually biopsy the vesicles or whatever. You actually biopsy adjacent to it, because there'll be increase, and you need to ask the lab to look for it, but they look for IgA deposits. And it's actually, or your sample should at least include some normal tissue as well. And that's where I think some people get caught out and think, this could be dermatitis herpetiformis, and do a punch biopsy, but they do it smack in the middle of the lesion and they don't actually then pick up. So you need to include normal tissue and it's sort of adjacent to the lesions themselves, and talk to your lab about it as well in terms of if there's anything else special you need to do about the sample.